Good day, my name is Imelda Williams. This is the feedback on the upper limb and shoulder practice bank that I've given you. So I trust that you have worked through the practice bank yourself. Please have your completed PAE form at hand so that you can self-mark this formative assessment. So in the first case, the indications were of a patient who fell onto the left shoulder, and there was also previous trauma to the same shoulder, so the request was for a left shoulder. So if we now view our with our software, and let's first look at the AP view. First thing that you will notice is that the humeral head is lying inferiorly. It's not within our glenohumeral joint, and it's also lying more medially. The other important thing to note is that there is an indentation on the posterior lateral corner of the humeral head. So this is visible on the AP view. It's also important to check whether there are any signs of any fractures. So there's nothing there. The only thing that we are picking up here is that it looks like there is some foreign body, and most probably that of a button. On the lateral view then, so on the lateral view you can now see the appearance of that foreign body really looks like a button. So on the lateral view here we have our Y view, and you can see that the humeral head is not sitting where it should be sitting. However, it's sitting inferiorly and it's lying medially. So then on our PAE form, first thing is this case is abnormal, so you need to tick that box. Then the alignment is abnormal. The bone, because of that indentation that we've seen, which is a Hill-Sachs deformity, that is abnormal. And of course the joint has been affected, so that is abnormal. There were no real major signs of soft tissue swelling. So overall comment is that there is an anterior dislocation of the left glenohumeral joint with the Hill-Sachs deformity, and that's what we've seen in the posterior lateral part of the humeral head. And then you could mention that the foreign body noted is most likely that of a button. With our next case, this is a patient who had been sent for a right hand with trauma to the middle and ring fingers. So now we have 3 views. So remember what I said, if you just want to see one of the views separately, so if we look at our PA view, and I'm just going to take you straight to where the pathology is. So if we view our proximal phalanges, and if we look at the third and then the fourth one on this image, you can see that there are fractures at the level of the epiphyseal plates. However, when we look at the fractures are above the epiphyseal plate, so that indicates Salter-Harris type 2 fractures. On the oblique views though, you can also pick that up, but the fifth one starts to look a bit suspicious. And then on the lateral view, we can see third, fourth, but also the fifth having Salter-Harris type 3 fractures, type 2 fractures. And then there is some minor alignment displacement. So then our PAE form, so it's abnormal. The alignment is abnormal and the bone is abnormal. Because it sits above the epiphyseal plate, it does not affect the joint, and there is not really some major soft tissue swelling there. So the overall PAE is that there is mildly displaced Salter-Harris type 2 fractures through the third, fourth, and fifth proximal phalanges. Okay, so for our case 3 then, so patient sent for a left wrist with a foot injury. And when we look at this case, we can see that the fractures at the distal part of the forearm, and it's a fracture of the distal radius. But when we look very carefully, we can see that those lines are going through the articular surface. So this is not a Colles fracture, however, it is a Barton's fracture. You can also see on the lateral view that it's through the articular surface. And the reason why it's a Barton's fracture is because if we would draw a line now, we'll be able to see that the fracture fragments are more posterior. So it's a Barton's and not a reverse Barton's fracture. Remembering our zone of vulnerability, so if we look very carefully, we can see that there is also a fracture, avulsion fracture of the ulnar styloid. So back to our form again. So it's abnormal. The alignment is abnormal. The bone has a fracture, and also the joint is affected because of the ulnar styloid and the fracture that it goes through the articular surface. So your overall PAE then is that the wrist is dorsally displaced, and there's a comminuted intra-articular fracture of the distal radius. That's in keeping with a Barton's fracture, and there's also an avulsion fracture of the ulnar styloid. Our case 4 is that of a forearm. And here you can see there's 2 images. So this patient fell from a motorbike and now has limited range of movement, and you can end with some significant soft tissue swelling. So on the AP view, so quite evident is that the ulnar has been fractured at 2 places, so that's comminuted, and there is also some displacement of the fragments. But very importantly, don't forget that we need to look at, because of the ring-like structure of the forearm, that we now need to look very carefully at the elbow. And if we draw a line, the radiocapitellar line, we'll be able to see that it misses the capitellum. So there's also a dislocation of the radial head. On our lateral view then, we can see the fracture fragments, but once again, when we draw a line through the radius, we can see that it does not intercept the capitellum. And then on the, if we view very carefully, we can then see the fractures of the ulnar. So, firstly, it is abnormal, the case, and then the alignment is abnormal because of the dislocation. We've got fractures of the bone. The elbow joint is abnormal, and there is significant soft tissue swelling. So the overall PAE is that there's mildly displaced comminuted fractures of the ulnar with an associated radial head dislocation. And this is in keeping with a Montague type fracture. Our next case is that of a hand, and the patient has had a punch injury. So if you look, and I'm just going to keep both of those open because it's just easier to see it like that. So on the PA view, we can see on the 5th metacarpal that there is a fracture at the neck of the 5th metacarpal, and you can see on the oblique that it is volarly displaced, and this is in keeping with a box of fractures. There's nothing else, so no joints are involved here, and also no significant soft tissue swelling either. So once again, it's an abnormal case, So because of the volar displacement, there is an alignment issue with the metacarpal, with the fifth metacarpal, and the bone is abnormal. So your overall preliminary image evaluation would be a volar, mildly displaced fracture at the neck of the fifth metacarpal, and this is in keeping with a Boxer's fracture. Okay, so for case 6, it's again a wrist, and this patient had a hyperflexion injury. Okay, so if we look at the PA view first, and if we just scrutinize the wrist area, we can see that the proximal carpal bones has lost all of the joint spaces. We can also see that the radial styloid process has a fracture, which is undisplaced, and then there's a quite visible scaphoid fat stripe. On the lateral view, though, when we now look for alignment, and if we draw a line, we are able to see that the lunate is still in contact with the radius. However, the capitate is now dislocated, so we have a perilunate dislocation. So on our PAE form then, it's abnormal, the alignment is abnormal, the cartilage and joint is abnormal. Sorry, the bone should also have been ticked as abnormal because of the styloid fracture, and then also there is some soft tissue abnormality. So the overall PAE is there's a perilunate dislocation as well as an undisplaced radial styloid fracture. Just included that because I didn't have it originally. Okay, so for case 7, we have a patient who fell from a skateboard onto the right elbow. So if we first look at the AP view, the main thing that we can see on the radial head is that there is a step on the cortex side, so there's an almost like overhanging of the cortex. And then on the lateral view, we can see, if we zoom in, we are able to see that there are multiple lucencies. So this is comminuted fractures of the olecranon process, but it's quite important when you have fractures close to the elbow joint is to check whether the alignment is normal. And if we draw the radiocapitalar line, that's normal. And if we draw the anterior humeral line, they all bisect the capitulum. Importantly, though, is that there is a normal variant, which we can see on the anterior humeral part, and that is called a humeral spur. So to complete the form then, it's an abnormal case. The alignment is abnormal because of the fractures that's been separated, but not because of the joint. The bone is abnormal because of the fractures. This is the elbow joint that's involved, and then there is soft tissue swellings. So there's a comminuted intra-articular fracture of the olecranon process, and also visible is a normal variant of the humeral spur. However, you could add a note here that there is no dislocation of the elbow joint. Our next case is that of an elbow, and it's a patient with a tender elbow after falling over. Okay, so in this case, if we look very carefully, and let's start with this view. we can see this is the radial head, and there looks like there is some abnormality there. However, if we draw our line, we can see that the radial head will still, intercept with the capitellum, and this is an oblique view, and here we can see that the radial head has been impacted. On the lateral view, we can see the impacted radial head fracture, but we can also note that there is quite an elevated anterior fat pad, and you can see a slightly elevated posterior fat pad. This is a normal variant. Okay, this is the olecranon. So don't confuse that for an avulsion fracture. Just is this an unfused center. So the case is abnormal. The bone is abnormal. It involves the elbow joint, and there is the elevated fat pads, which makes it the soft tissues abnormal. So the overall preliminary image evaluation should be something like there's a mildly displaced, mildly impacted, radial head fracture with elevated fat pads. For case 9, we have a shoulder, and this patient was knocked off a bike. Okay, so looking at the AP view, if we zoom in, it's quite evident that there is a fracture of the scapula, and it sits at the level of the anatomic and surgical neck. You can also see that there are multiple lucencies. Quite important, when we check for alignment, we can see that the AC joint is normal. And I think the next one actually shows the fracture much better. So you can see where the fracture is there, and similar here as well. Okay, so on our form then, it's abnormal, and the bone is abnormal. It doesn't involve the joint, and it's a comminuted fracture of the scapula. And then our final case, it's a patient who fell onto the wrist, right wrist, and query a fall or a fracture. So on the AP view, so if we just again pick up our magnifier, we are able to see that this cortex is intact on the one side, but it's disrupted on the other side. So there is a disruption. You can see there's a lucency there, and then on the lateral view, you can also see that it's disrupted on the one side. You can also see there is a displaced pronator quadratus fat pad. And the oblique view actually shows that there's a break in the cortex. You can see there's a lucent line, so it's not just a torus fracture. Okay, so for this case then, it will be abnormal. The bone is abnormal, and then with the displaced pronator quadratus fat pad, so the soft tissue is abnormal. So it's a green stick fracture of the right distal radius. So that concludes the 10 practice bank cases, but I did promise you that I will provide feedback on the slides that I've given of the images, the additional images. So if we now look at the apiclavicle, that was in part A. So hopefully you've done that yourself so that you can work through these. So your number A here is the sternoclavicular joint. Number B is the sternal extremity. C is the body of the clavicle. D is the acromion extremity, and then E is the acromioclavicular joint. So that is for the AP of the clavicle. The next image that I gave you was that of an AP of the scapula. So A is the acromion, B is the neck of the scapula, C is the scapular notch, and D is the superior angle, where E is the vertebral angle, F is the inferior angle, and then G would be the lateral angle, and H will be our glenoid cavity. Now looking at the inferior superior axial projection, where A would be our coracoid cavity, B is the glenoid cavity, C is the spine of the scapula, and D is the acromion. So it's useful if you want to look at any dislocations. Okay, thank you very much. So if you have any queries with anything that I have discussed, please feel free to contact me. Thank you.